All right, guys. Well, welcome back to another episode of Claims Denied. So we're doing something slightly different today. A format I've been wanting to test out. I think it's going to be a lot of fun. I've got two wonderful, intelligent, amazing folks with me on this podcast, and we're not doing an interview. They are not guests. They are co-hosts. And today we've been rumbling in the background about three topics we think are top of mind and very present in today's healthcare dialogue. And we're going to walk through those topics. But before we get into the meat of the discussion, I would love for you guys to introduce yourselves to the Hospitalogy readership, listenership, however you want to describe it. And Tiera, how about you go first?
Sure. Thanks, Blake, and great to be here with you and Dr. Eric Bricker. I'm Teira Gunlock, CEO of First Stop Health. First Stop Health is a direct virtual care practice in all 50 states. We serve primarily the mid-market and give people super easy, affordable, delightful experiences within healthcare. My background was I grew up on a farm. And so I think through that, just saw the joy in problem solving day in and day out. And so what better place to spend time than in healthcare, which is so rich with things that we can solve. So delighted to be here.
That's awesome. Thanks so much for being here. Really excited for you to be a part of this. And then Dr. Eric Bricker, would love for you to bring us home here.
Well, thank you so much, Blake, for having me, and congratulations on what you've turned Hospitalogy into. I mean, this thing has grown and grown and grown, and I have heard people talking about Hospitalogy. Thank you to all the Hospitalogy readers and listeners for tuning in. And so, little secret, Tiera and I used to work together. So I used to be the chief medical officer of First Stop Health. And Tiera, of course, being the modest person that she is, she was one of the very early employees at First Stop Health. And she basically worked her way up through the ranks and basically has grown First Stop Health from this teeny startup into like being in all 50 states and having literally tens of thousands of patients across the country that they support. And it is just awesome to see what she has built there. So congratulations to her and the First Stop Health team for what they've accomplished. And I'm an internist. I'm here in Dallas. I originally started out as a hospital revenue cycle consultant back in the 90s, helping docs and hospitals get paid. Then went on to medical school at the University of Illinois and then residency at Johns Hopkins in Baltimore. I thought I wanted to be a policy wonk and work at CMS, but that changed. So I decided to go the entrepreneurial route, and I started a health navigation company actually in residency called Compass Professional Health Services. And then I moved down to Dallas with my business partners in 2007 to work on that business while I was also sort of moonlighting as a hospitalist at a local hospital as well. And we grew Compass. We contracted with employers. We grew that to about 2,000 employer clients, about 1.8 million people that we helped navigate the U.S. healthcare system. And we sold that business in 2018. And then I found myself without a business. And so I'm like, actually kind of shoot people straight and kind of let them know what I learned about the healthcare system. And that's why I do these AHealthcareZ videos on YouTube and LinkedIn. And literally they've been watched millions of times. I'm shocked that people are interested in healthcare finance education. It's incredibly boring, but I try to liven it up a little bit. And so it's an honor and a pleasure to be here.
Awesome. Well, you guys heard it from the horse's mouth from both of these people there. Very well accomplished, very experienced in healthcare, and they have lots of things to say. Tiera, from what I understand, Dr. Bricker just told me you are a philosophy major, so it sounds like you're pretty equipped for debate.
I was maybe 20 years ago when I was in school.
Well, sure. What's the most interesting philosophical thing you studied?
Honestly, I think it's the interplay of different philosophies and their application to everyday care. So I think a lot of different, there's a lot of different principles out there, a lot of different types of, there's utilitarian and maximize the most good, and there's different rules-based types of philosophies. And I think there's nuggets within each that can be applied to kind of how we run. And I pull things out. So Immanuel Kant was, famous for the categorical imperative. And it's basically, like, what can you do repeatedly while it's still being a good thing? And I think that has been a great lesson in scale as we've, scaled the organization. But there's lots of other things that I think I pull out of all the time in terms of, who I reach to for that wisdom, including Eric, who all my best sound bites are probably going to come from him.
Thank you. Thank you for that.
And so, and that's awesome. And, would love to hear more about your beliefs. And it seems like you are a deep thinker. So wonderful. And Eric, from what I understand, so there's a connection here beyond First Stop Health, which I think you kind of live on a farm now, do you not? Out in McKinney?
I do. We've got longhorns and chickens and alpacas, and I am trying to. I grew up in the suburbs. I'm a suburban kid, so I have no idea what I'm doing. So I probably could take some lessons from Tiera.
Yeah, I think we would refer to you as a city boy, where I come from. So.
Well, I am 100% a city
don't
boy.
get between a bull and the rest of the herd. I've done that before. That's a bad idea.
I've got a funny story. So the first time, Eric, you and I were supposed to meet for lunch, I'm at the Fish City Grill in Dallas, and I get a text or a call from you. And from what I understand, you had, maybe a chicken had been caught in some wire or something. And so you were just very caught up in getting that chicken out. So hopefully that chicken's in a better spot now. And my lunch was excellent.
So I guess we saw Blake for lunch. And I was sorry. I felt horrible about it. Literally, we ate like this dying chicken, which I should sound more sensitive. But listen, if you have chickens, listen, just go. Like that's just how it is. Like you're just gonna lose some chickens. That's part of the chicken business. So anyway, yes, Blake, you've been very kind to forgive me of that.
And how would you relate your comments just now about chickens and letting them die to healthcare? I'm just kidding. I'm just teasing. All right, guys. Well, pleasantries aside, super excited for today's discussion. We picked 3 areas that I think are very top of mind, and I don't think it would be a healthcare podcast, especially in 2026, if we didn't talk a little bit about artificial intelligence and the current state of things. There's been a ton of discussion around, really legislation and regulation of AI. Obviously you have the kind of tech bro, techno optimist mode where you're like, hey, let's try to break everything as much as possible and move as quickly as possible and innovate. Obviously, that does not jive well with the conservatism of healthcare. And so much of the discussion I've been a part of over the past, year plus, panels, side conversations, whatever it is, has discussed how do we find a middle ground, where are guardrails, but also there's kind of been this interesting, almost like self-driving car, I would characterize it, problem in healthcare where, arguably in many instances, AI can be used to expand access or help with maybe certain surgeries or, preventive measures and those sorts of things. But whenever it makes a mistake, similar to how a self-driving car, whenever, Waymo kills the neighborhood cat, right? Kind of thing. That mistake is always in the news, right? So really would love to dive into topic 1, hear what you guys are seeing and thinking about AI in healthcare. What's the right level of regulation? What are interesting initiatives you see? And Tiera, maybe let's start with you and we can kind of go around the horn or just kind of have a natural dialogue from there.
Okay, great. Because I have the perfect solution. I've got it all figured out.
Oh, perfect.
I think it's really hard. I think fundamentally the regulatory structure is iterative at best if it's working, right? It's iterative at best. And then we have this kind of revolutionary technology that is like growing by leaps and bounds. And so those two things are just they're not going to meet very well, right? And so I think there's some mismatch there for even how they're conceiving of a lot of the regulations. The other thing that I would say is that a lot of what I've heard from a regulatory standpoint or a lot of the debate tends to conceive AI as a tool as opposed to an agent or a part of the care team. And one of my curiosities is just kind of like, how do we think about, whether it's like FDA regulation versus like provider licensing at the state level, and where does it actually belong and kind of who makes that call? And because I haven't seen a lot of discussions about this actually being part of a care team, and actually there's a lot of possibility for it to be, and to free up a lot of the other providers' space and scope to treat more patients or to actually practice within the scope of their license or even go above, as those things shift over time. But yeah, I think that's kind of one of my one of the things that I've been interested in. I'd be curious, Eric, what your take is on the licensing element and kind of where you think AI belongs.
Yeah, this is a huge, like multifaceted like area. So one, there's obviously issues around AI as, decision support / making decisions for the doctors, whether it be like reading the film for the radiologist or assisting with the medical decision making for the primary care doctor or what have you. And so there it becomes into issues of liability, right? So pretty much right now, any practice that's going to be using the AI, the physicians are going to assume liability, through their license and through their malpractice, which might be through the hospital system that they work for or what have you. And so there's going to obviously, if something bad happens, it's like, well, potentially they're just going to go after everybody. And what are the rules around that? And that's unclear. Okay. So that's like definitely one thing that is going to be like worked out over time. But I would say that, really in my opinion, there's like, let's go there right away. The fact that AI has moved into this agentic world where healthcare is filled with mouse clicks, right? So here you have clinicians, and that could be a doctor. I mean, we never even talked about how much nurses spend in documentation. So I'm married to a nurse. Okay, so the amount of time that nurses spend in documentation could be much better spent on something else. And so obviously you can think of like AI scribes as like a sort of a form of agentic AI, but there are so many other workflows within whether it's the EMR or other software systems. And this is where we have an issue with Epic and the other very large electronic medical record systems because they're not necessarily open. And so you can think of it as like your iPhone with the App Store. They just have this, or even Salesforce.com did this, right? They decided it's an open architecture and they're going to allow external parties to then have apps in there. And to a certain extent, the EMR companies have not necessarily been as open around that. And so you're then beholden to what the EMR company itself is going to design from an agentic AI perspective, which obviously, if you had more companies competing to create agentic AI solutions on that EMR platform, that would be much more helpful than having to stick. And it's just like the classic, like Steve Jobs didn't want the App Store. He's like, I want Apple to create all the apps because I need control. And his colleagues actually convinced him otherwise. And he was smart enough to swallow his pride and listen to his colleagues and not to himself. And as a result of that, we have a much more functional iPhone experience than we would have had it been a closed system. And so would there need to be regulation to actually force those EMR companies to open up their architecture to allow outside agentic AI to come in? In my opinion, yes, that would be super helpful.
No, that point is interesting, Eric, around the EMRs and kind of the walled garden, like economics, like business case, right? Because as the Apple, you want to keep everything within your ecosystem, and AI very much so existentially creates a problem where you become quickly commoditized, right? And you're the system of record. So from my standpoint, a lot of these agentic AI companies are trying to build that system of intelligence. And you think about it, some folks have postulated, and I think this is maybe a little far-fetched, but if you're capturing all the documentation via scribing technology, that almost over time can become the EMR in a way, right? Because all the documentation is there. And I know there's not like the history and like I'm not a health IT interop expert, so I don't know what else goes into that. So I might be, speaking out of my shoes here, but it is an interesting philosophical question about, future role of the EMR and the need for greater data liquidity as technology and AI becomes faster. And
the one thing I would add to that is that really electronic medical record is actually a bad name for it, because what it is it's actually the clinical workflow software. That's really what it is. The quote unquote record keeping is actually only a small part of what actually it does. And that's actually even like a small part of what actually takes the doctors and the nurses and the respiratory therapists and the physical therapist. That's actually a small fraction of the time it actually takes. It's actually the order workflow within there that you could 100% apply agentic AI to that. And that would be it would improve patient safety. It would save the clinician's time. It would save a ton of money with redundant FTEs. Mm-hmm. So again, there's, to the extent that you can have an open system and have like a multitude of companies working on that problem, it would probably be better.
Yeah. I mean, it's just generally a less brittle structure than what we have had. So it allows for more, for faster innovation. And the only add that I would have there, it's a clinical workflow and billing system, I would say, for most of those EHRs in terms of how they've been designed. But yeah, I totally agree.
Yeah, makes a ton of sense. Appreciate that color. And Eric, something else you mentioned was around kind of, a big conversations surfaced around AI and the liability, right? I totally agree with that framing, but an interesting perspective I heard, and I've talked to a couple of folks around like malpractice and the future of malpractice, and I asked this question. I posed this question to an executive and said, like, at some point, assuming AI continues its current trajectory, adoption levels, technological prowess, et cetera, you would think eventually, like, could it be malpractice not to use AI, like, as part of your clinical work? And I'd love to pose that question to you and see, like, maybe AI helps reduce cost and administrative costs in the sense of like malpractice insurance, malpractice premiums, similar to how like, maybe a car in car insurance, if it deems you're a safer driver, that lowers your premium, right? So curious if you've kind of discussed anything around, either of you guys have discussed anything around that kind of dynamic.
Well, I would tell you that First Stop Health has a ton of doctors, so I would love to hear Tiera's thoughts on that.
I mean, I do think that it's, your question is almost kind of like having me think of, back in the 90s, right? It's like if you fast forward and those doctors are now suddenly practicing medicine without any sort of electronic health record. It's like, that's not good medicine, right? Like it's fundamentally not good medicine. I think we're probably going to be headed in that same direction in certain ways, but probably faster. There are going to be gains that happen. I think to me, the biggest question from an AI front is just like, it's going to change things. And the question is kind of like who benefits most. My hope would be providers in terms of, we can actually focus on the care of the patient. We can do more human oriented value things. My hope would be the patient, right? That it's like, oh my gosh, more people have access, more people can afford care, all those types of things. That's my hope. Don't know that necessarily the incentive structures are set up in a way that will actually be the outcome, at least initially. But that would be my hope. Because I think, on our platform, we've tried to simplify the workflows. We're direct care, so we don't have billing workflows within our EHR. And I think that's something that providers really appreciate. And there's so much more we can do to help them actually free up their time and free up that cognitive load so they can focus on the patient.
Okay, yeah, that's super helpful. And maybe a follow-up question, just to that as an operator in the space is, we alluded a little bit to kind of AI legislation and regulation, those sorts of things. As you're deploying or thinking about AI, first of all, where have you found kind of best use cases today? And then two, have you had to grapple with any sort of regulatory requirements state by state? How has that kind of played out?
The biggest gain, honestly, already is within the software development lifecycle. So, and I think we are among the many companies that are seeing those gains, and it's still very early. To give you an example, like former software development lifecycle, you produce a number of, we'll say, outcomes, per release. The first time that we had fully changed, not to just tooling, but fully changed to an AI development lifecycle, which is not just like having a thing over here that helps you. But once we'd fully made that transition, the very first time out of the gate, we were 5x more productive, right? And that's like just the beginning. And so I think, but it also just has me kind of curious in terms of, that was a fundamental workflow change. Like the person who is coding is now reviewing documentation. They're not writing code, right? They're reviewing documentation to make sure it's good, to pass it along to the next agent to quality check it, to then have another person that then reviews documentation. It's a fundamental shift in their job. And so the question is, I think, for other types of providers, what will that new life cycle and workflow be for them besides just working in the current constructs of making them more efficient and better, having better documentation? It's like, but what's the actual new workflow for, basic, screenings and some of those types of things? I don't know. I'd be curious, Eric, what you think on that.
Yeah, 100%. So healthcare is notorious for having monstrously large IT backlogs. right? I mean, it is,
Yep.
yeah, put it on the list. We'll get to it in 18 months if you're lucky. Okay. And so to be able to accelerate that process is, and not to be hyperbolic, but in many ways, it's sort of like the IT department's dream, because they have just been, they've been doing the best they can, but a lot of this stuff just has taken so much time historically that now to be able to accelerate that is just, I mean, it's awesome.
And Tiera, you kind of alluded to this, and so maybe we can get into this next as folks who are either are physicians or close to physicians. How does the role of various specialty, how do the roles of various specialties evolve over time, given the prevalence of AI? And the way I think about this, kind of framing it up, is you think about the radiologist, right? And there are certain professions, certain specialties that are deemed more kind of disruptable from a technological perspective versus maybe something more hands-on, general surgery or whatever it is. So I don't know. I think there's been a lot of speculation and discussion around, hey, like maybe we can carve out like rural healthcare or critical access hospitals and let them deploy agentic AI to read scans, like 85% of like normal scans or whatever, right? So I would love y'all's thoughts on whether you think that that's good, bad, somewhere in the middle. I'm sure there's nuance here, but Eric, maybe we start with you.
Yeah, no, it's 100% good. Okay, you got to understand that we have a severe radiologist shortage, to the point where the radiologists in the beginning of their second year of residency, radiologist 4-year residency, in the beginning of their second year of residency, they're getting job offers, because all of the folks that are hiring, whether it be a hospital system or a radiology group or what have you, they gotta get them early. And so the reason why there's such a shortage is because the volume of imaging has gone through the roof. Whether it's, aging of the population, blah, blah, blah. There's not enough people to read all of the scanning that goes on in America. And so as a result of that, now I have several very good friends who are radiologists from medical school. And so what they've been able to do is they've actually been able to grow their practice, and they do gobs of telerads coverage. So they're covering their local hospital system, their local area, whatever, but they also have gobs of telerad coverage where they're doing it for like remote areas and rural areas. And then they also have radiologists that they employ that don't even live in their like metro area. They've got folks, they're in, he's in their hospital systems in Florida. They got radiologists that they employ that are in Missouri that are doing the reads on this. And so in order to be able to keep up with the volume, then it really comes down to like access. It's like, okay, so we actually will be able to give people because you got to understand, if you're a diagnostic radiologist, depending upon your coverage or whatever, you're doing a fair number of procedures as well. Like you're doing your lumbar punctures. Sometimes you're putting in chest tubes, but you're doing like paracentesis or thoracentesis or what have you as well. And so like anytime you do one of these procedures, you're backed up with films that you're not reading. And so then everything else just backs up, right? Your ER turnaround time backs up, and then your admission time backs up, and then your discharges back up. So you're really enabling access by having the radiologist use the AI. So it's not a question of if, it's really just a question of when. Like it's going to happen.
If you pull those routine scans out of his or her backlog, does that affect their productivity metrics or physician compensation, level of compensation, like those sorts of things? Because I feel like when it comes back to like financials, when it comes to behavior change and desire for innovation, right? So I wonder if there's a model where like you get paid like X% of an RVU with an AI assisted scan, or.
So the short answer is that at the end of the day, like it's going to be subject to competition. And so I can tell you right now that radiology groups that can go through stuff faster, they'll just underbid another competing radiology group to do the contract with a particular hospital system. They'll say, okay, we'll read it for at the very base level, most of the radiology groups get stipends from the hospital systems in addition to the RVUs that they're actually reading and billing for. And so a radiology group could go into a hospital system and be like, what's the zero stipend? Because we don't need to charge $500,000 a year or $1 million a year or whatever, because we're so efficient that we can spend less on radiologist FTEs in order to read the same number of films. And so they're literally doing that today. I mean, you're literally starting to have price competition across radiology groups. And again, they're not geographically limited because they can do teleradiology. So they can go in and compete in Florida or Missouri, even if the radiologists like aren't even there.
Yeah, that's so interesting because I hear that and it sounds like maybe I don't know. I don't know what the time frame would be, but currently there's a shortage, right? There's a supply shortage. And I hear in these earnings calls and in hospital income statements like, oh, our professional fees, our subsidies, stipends, etc., are out of control. Like we can't control these costs. That sounds like an interesting friction point, between maybe, call them private equity backed aggregators who have cornered the market and or market power physician radiologist etc versus introduction of AI and increased supply and competition from your perspective. I don't know if I necessarily have a conclusion here, but I do think that's just an interesting dynamic to point out.
Yeah. I mean, the incentives for them to fundamentally charge a lot less, right, to those health systems aren't there. So it's like
Right.
they're going to charge
Right.
just enough, right, to capture that business. And that I think probably for where we are in the innovation cycle, that's probably just going to play out. But at some point, the question is, I think, do we want to change the incentives if we actually want to drive down cost?
It's a great question. So how do we change the incentives? Is it changing the comp model? Is it moving to global cap? Like what do you guys think is path forward?
The application of AI in revenue cycle management, RCM. I mean, that's like the big area right now, which from a big picture perspective, if you're a hospital system or a physician practice, you're a quote unquote healthcare provider what are you doing there? It's not to improve top line revenue. Okay. You're not using AI to decrease your operating costs. And so really, and that's like the low hanging fruit because of course, all healthcare providers, they want to grow revenue. That's sexy. That's fun. That's positive. You don't have to lay people off if you do that. Right. So
Yeah.
that's only going to go so far. Okay. And then then you get into stage 2, which is using AI for operational efficiency, which potentially would result in like layoffs. Okay. So who will adopt that? When will it be adopted? I don't know, but I will tell you that HCA and Tenet and UHS have shareholders. And if anybody's going to do it, the publicly traded hospital systems are going to do it before anybody else will. So if there is a quote unquote canary in the coal mine, they're going to be the first ones to do it.
Such a great point. I've written about this a decent bit, and I've asked the question to at least a couple health system folks. Hey, if you're looking up and you have this AI use case you've built in-house or looking to partner and, it could cut 2/3 of your cost, but it would result in, reduction in workforce or complete phase out of a department or whatever that looks like, would you do it? And, or like, how would that play out politically? Because from a nonprofit standpoint, there's local market political pressure to maintain jobs. They're big employers in lots of markets across the country. And most of the response I've gotten so far is, hey, there's so much work to go around. We'll be able to reskill and replace and those sorts of things. But I don't know. I just feel like that's maybe a little bit of a cop-out. And these are more tech-forward companies, but Block and a few other companies in kind of fintech and other areas did more draconian methodologies where they went out and said, hey, we're going to cut 40% of our workforce today, right now, because we think that they can all be replaced with AI. And the folks that are still here, like, you're here for the long haul kind of thing. And whether that's true or not, who knows? But the rate of technological adoption with AI, healthcare is leading from an enterprise perspective. And so there's a friction between how much we're deploying versus the level of waste, right? Like administrative streamlining that can be done, and something needs to give eventually.
I will say, I think it's only partially a cop out, in that I think the future workforce fundamentally will need to look different if we want to provide better outcomes, increase access, increase affordability, all those types of things. Like the people doing their things, right? Their jobs, that's going to need to look different. I think the question is how we get there and whether or not those institutions, especially the very large institutions, will actually invest in the reskilling. It's like, yes, there's plenty of work to go around, but are you going to give these people the opportunity and the training to transition? Or are you just going to do a fundamental kind of swap out? And I think the answer will be different based on the institution, probably in the needs. But I do think that it's like, we have to be wide-eyed that like the workforce will look different over time. The question is how we want to approach that. And I think if healthcare has a moral imperative to actually invest more than perhaps other industries in that reskilling.
I think my final point on this AI discussion, first off, I think there's a lot of interesting dialogue and technological shift happening, especially in primary care, which I'd be curious for y'all's opinion on, especially, in rural settings, or there's been one or two companies recently that have been funded. One guy who used to run like a dating app, and now he's like trying to offer free AI-enabled primary care, essentially, where like you're basically talking to an AI bot or like agent or whatever, and that's kind of your entry into the system. And I'm sure they monetize some way through, I don't know, supplements or ads or something like that. I have no idea the monetization strategy, but I do think it speaks to a larger trend around what's been happening secularly for quite a while with professional reimbursement declining, primary care economically not working great outside of like a larger vehicle that can capture downstream economics, whether that's, OR or value-based care, capitated models on the payer side, those sorts of things. So maybe my question for you guys is, where does kind of AI in primary care end up? If we're able to expand access, but it's maybe worse quality care from the standpoint of maybe you're getting less time from a nurse practitioner, but more technology from an AI agent, right? Is that better overall for society? I think those are kind of the questions that maybe we'll need to grapple with from a population health standpoint, but would love for you guys to chime in with any thoughts on the primary care front.
We're in luck because like that's what First Stop Health does. Go for it.
Sponsored by First Stop Health.
I think long term, right? So the primary care that we provide is team-based primary care. We have physicians, but we also have registered dietitians and diabetes educators, and really trying to coordinate as a team, because fundamentally a physician doesn't necessarily need to do some of the nutritional coaching that a nutritionist is better suited to do. And it allows people to, better work at their license. And I think, so that's the current team. The future team is probably also got an agent in there, or two or three, right? So they are different. It's a different team that is providing that care, and hopefully to more patients, and even more delightfully. So that's my hope and my kind of vision for primary care. From an access question, I think one of the things that keeps kind of coming to mind is around whether we will use this opportunity to kind of close some of the inequities or compound them. And so what I would hope we wouldn't have is that, rural healthcare and, people that can't afford as much healthcare, they get bots. Everybody else gets like human-centered care, right? And I will say, it's like, so that is a worry that I have. And also I would say that like for a lot of these folks, bot care will be better than not care. So, yeah, I think there's some concerns there. I think there's also an opportunity to do more than what we have had, been able to do for these people. I don't know, Eric, thoughts?
So I think that we have seen, APPs, advanced practice providers, whether it be a nurse practitioner or a physician's associate, we don't call them physician's assistants anymore. Okay. So their role in primary care and even in specialty care has exploded. And frankly, it's going to explode even more through the use of AI. And so the way that actual clinical decision-making happens is that you have two data sets. You have the actual patient data set themselves, where they talk about their history, and you do physical exam, and maybe you do labs, you check vitals, et cetera, et cetera. And then you compare that to the second data set, which is the compendium of medical knowledge that you have. And it's the interaction of the two that then again gives you a diagnosis and a treatment plan. Like that's literally all a doctor does. Okay. And then obviously if you're a proceduralist, you have the surgical skill or the procedural skill to actually implement what it is that you're doing. Right. Okay.
Yeah.
So
super easy. We could all do it.
It's not that complicated. Okay. Part of a physician is like the mystique of like, there is no mystique in what we do. Okay. Right. So here's the deal is that in general, we always solved for the second data set first. We trained a bunch of brainiacs who were really good at creating that number 2 data set in their brains so that they could immediately access it. The problem is that the people who are really good at the second data set are not necessarily good at the first data set. And so, frankly, there are a lot of APPs that, frankly, have much better patient interactions. Now, of course, you have your outliers. You can see physicians that are just awesome at both, right? But at the end of the day, the number of those people that exist is not enough to serve the population that needs them. Okay, so we need to use the population that's actually better at interacting with patients and better at forming relationships and better at listening, and better at giving access, and then supporting them with AI as the second database, which is why we've seen so much spontaneous adoption of open evidence. I have no connection with open evidence at all, but this is the compendium of medical knowledge that you're able to access through an AI LLM, and doctors are spontaneously using it. Okay, so every time you get doctors just spontaneously using something, that must mean that there's sort of deficiency that the doctors are trying to solve for to help their patients. Because, of course, no doctor has the entire medical compendium memorized in their brain. And if you can actually then use APPs enabled by this incredible, compendium of medical knowledge in an LLM, like I think it's the future. And it's about, and so that's where the physicians, believe me, they will need to have a role. But, and it's not, and this happens in urology. I literally was just talking to a urologist in Tennessee last week. Guess what they're doing? They're hiring gobs of APPs for urology clinic. They may not necessarily be doing the procedures, or they're only doing basic procedures, like they're putting in Foley's or whatever. That's a catheter in the bladder. Okay, but like they're specifically basically teaching them the specific urologic compendium of knowledge that they need to have, right? What if you could massively accelerate that process through AI so that you didn't have to send them through this boot camp to become a urology APP? Will it happen? I don't know. It easily could happen in the next 6 months. I mean, you could have an enterprising primary care doctor, an enterprising urologist, literally make that happen in a matter of weeks. And so I actually am incredibly you can tell I'm incredibly optimistic about this, and so many of our problems are going to be solved. And it obviously it needs to be done in a responsible way, et cetera, et cetera, et cetera. But don't let the Luddites stop you, right? Because there were Luddites with the internet, right? So just right, there would be, we need the yellow pages, right? If I say yellow pages in front of my kids, they have no clue what that is, right? So it will change.
Can I ask you a question? Do you think that the future, so I'm going to generalize here, which is probably never a good practice, but I'm going to do it anyway. But it's so historically, right, the physician was the smartest person in the room. And I'm curious if you think that the future physician 30 years from now is maybe no longer the smartest person, but just the person who's best equipped to build trust with patients. Or is physician more likely to move to oversight? And then the APPs are the ones that are very equipped to build trust. Any thoughts?
Yeah. Yeah, so there will always be, in my opinion, there will always be the human interface. So I don't think we are literally going to have the bots replace the docs when they're interacting with patients. It will be a AI enabled person. At a very basic level, the most engaging thing for our brains when we're communicating is the human face. And so people watch podcasts. Why are people watching podcasts? They could just listen to them, because actually seeing human faces is incredibly engaging for us. Will there be a future where robotic, humanoid robots will completely who knows? Okay, I'm not going there. I'm talking 6 months to 2 years from now is what I'm talking about. Okay, it will always be enabled by the person, and that person is going to do things like motivational interviewing. I'll say this very briefly. We moved from a world where physical labor was taken over by machines so that we could do intellectual labor. And we're moving to a world where intellectual labor is being taken over so that we can do emotional labor. So the next frontier of work is actually emotional work. It's actually EQ, emotional quotient work. That's actually the future of many jobs, not just in medicine, but we don't think about the physical burden of so much of what we do because we have machines to do that. And we're going to live in a world where we don't have to worry about the intellectual burden, but that's going to cause us as a society to actually up our skills emotionally. And we're going to have a tremendous premium in the world for emotional skills. And frankly, I actually think that's a fantastic direction for humanity. I think that's the right direction for humanity.
Yeah, it allows us to be our most human selves, right? It's like, so yeah, that was very well said.
Yeah, I find it so paradoxical because AI, in a sense, is almost having the opposite effect in healthcare because, like, to y'all's point, it's going to require a greater amount of trust, and we are going to need to lean into the human parts of healthcare, and that's what technology is enabling. Versus, I think about something like media or being a creator. It's like there are a lot of people using AI to like create AI generated comments on LinkedIn and other social media platforms and those sorts of things, which, in my opinion, is creating this great sterilization effect of and maybe almost spam effect where, maybe everybody's at a baseline level or floor level of being able to write or communicate now, but they don't necessarily are critically thinking or being thoughtful. And so maybe to bring that all the way back around, from my perspective, I think a lot about how do I stay relevant or keep my job sustainable, and you lean into the human components as well. Like you lean into like, how can I foster connection and authenticity and intimacy with my audience? And I think that that's a parallel to what physicians and other clinicians are probably going to need to lean into as well, to y'all's point. So yeah, I think that's been a really great discussion overview of kind of, current state of AI and clinical workforce and all of the
I'm
above.
just glad we solved it.
Right. Yeah. We got all the answers here for sure. For sure. And so a couple of models, and you guys feel free to chime in if there's any extra things you guys would like to add. There's two models that have kind of been emerging recently from a cost savings or containment or alternative model perspective. And the first one is ICHRA, which came around, I think around COVID time. It stands for Individual Coverage Health Reimbursement Arrangement. It is a defined benefits arrangement where you basically say, hey, whoever's kind of helping me facilitate this, TPA or whoever, I have X amount of money and the employee can go, this is tax-free, they can go buy their own coverage on the individual market. And so more or less to date, that market is projected to be around, I think HHS projects 800,000 employers offering ICHRA within the next decade. So fairly sizable, but ICHRA has really kind of went through this boom bust cycle fairly quickly. And I'm not saying completely bust, and we'd love y'all's opinions on that. A ton of companies got funded, and it was, thought of as this next, the next kind of 401k, but for healthcare, kind of thing. And now that the market has kind of settled down into maybe like the small and mid-sized employer market, and maybe not so much other areas. And so that's kind of where ICHRA sits today. And then model 2 is the group captive model. And maybe if one of you guys would want to give an overview of that'd be fantastic.
I think the simplest way to understand a captive is that it's basically a group purchasing organization, right? It's like, so it's all these self-insured companies that, you self-insure because you want more ownership over the results, but yet there's still risk in any pool. And so once you have a bigger pool, you're lowering some of those kind of greater risks. And so that's like that headline understanding. There's lots of other dynamics there as well, but that's like the headline. I'm hearing more and more, I would say, about captives these days. I think, size dependent certainly for both of those things, but I think, it continues to kind of be part of the conversation.
So it's essentially collective bargaining on that side, more or less. Is that kind of
specifically on their stop loss coverage for being self-funded?
Okay.
And so this is where historically, if you went self-funded and you went, and this is primarily for employers that historically were not self-funded. So typically like employers with less than 200 employees who historically were in the fully insured world, and that has just become very expensive. So their renewals this past year have been anywhere 30, 40, 70, even 80% premium increases for fully insured groups under 200.
Wow.
It's been astronomical. Basically, the carriers got hit hard on their Medicare Advantage business, so they really turned up the premiums on the fully insured commercial business. And so if you're a fully insured employer, then you basically have one of two choices. And so Blake, what we're discussing here about captive versus ICHRA, it's kind of like if you're fully insured, sometimes you got to go one way or the other. You're either going to say, we're going to join a captive and go self-funded, or we're just going to get out of the business totally and just go ICHRA. Okay. But you're not just going to stay in the fully insured world and take your 80% renewal. And so that's where on the captive, historically, if you try to go out and get stop loss insurance as a self-funded employer with like 80 employees, you would get something called a laser in your stop loss coverage, which said that if you had somebody that went on dialysis, that the coverage, your stop loss coverage would then no longer apply to that one person who was on dialysis. So in other words, you had stop loss coverage except thing you actually needed stop loss coverage for, the person on dialysis, right? And so, or they would just increase your premiums, what it would cost to pay for that person's dialysis. Like, oh, you want us to cover the dialysis? We'll just raise your premium by $250,000 and we'll use it to pay for the person's dialysis. So if you join a captive and you pool all these smaller self-funded groups together, then you can go out to a reinsurance company and they'll be like, okay, we'll actually insure this larger pool of employers and we'll issue a policy that does not have a laser in it. And that gives the employers a lot more confidence than when they go to a self-funding arrangement. So now on the ICHRA side, there to just split hairs a little bit on the terminology. So there, ICHRA is not defined benefit, it's defined contribution. So ICHRA is analogous to 401k, whereas fully insured is more analogous to a pension. So a pension is a defined benefit. Okay. And so by ICHRA being defined contribution, the employer's like, yeah, we'll give you $1,000 a month or $800 a month to go out onto the Affordable Care Act exchange or, the whatever exchange your state has, and you buy an individual or a family plan with that money. And what makes it a quote unquote ICHRA or an HRA is that they're using pre-tax money to do that. And then you can go out and you probably can qualify, for a subsidy, et cetera, et cetera. But what it does is it basically gets the employer out of the health insurance business, because then they have a defined contribution of $800 a month or $1,000 a month. And they can just be like, I don't even care what healthcare inflation is, because next year I'm just going to keep giving you $800. And then the year after that, I'm just going to keep giving you $800. And you, the employee, you're going to choose. Now there's benefits to that in that the type of coverage that a 24-year-old male needs is very different than what a family of 5 needs with like 2 adults in their 40s and 3 kids, right? So the types of whereas historically, both of those people kind of had to have the same kind of coverage, or maybe they had 2 options, right? So that flexibility and being able to choose the type of coverage that's more appropriate for you, it's actually super helpful. Now, the challenge where the rubber meets the road on the ICHRAs and why they've run into a stumbling block in terms of not being able to be adopted is because those policies on the exchanges oftentimes have fairly small networks. And so if you go out and you're like, oh, okay, I want to, or they're just an HM, you can't get like a broad network PPO policy. Like in some places, like you literally can't get one. You're either going to have a very narrow network or you're going to have an HMO, but to kind of have this broad network PPO option on the, and so interestingly, for those small employers, it's really like the business owner and the handful of executives that he or she like needs to keep employed. And they're like, yeah, like, like Sally. It's like if Sally leaves, the business is used, right? And Sally's like, I'm going to leave if I have to go onto one of these exchange plans, right? And so they're like, well, I literally cannot have Sally leave because she's your number one salesperson. There's no way that I can have Sally leave. So I'm not gonna move to an ICHRA because it's just too devastating to the business because the network access is too bad. So that's kind of the 2 choices. Okay. And as you can imagine, what most employers have done, it's quo. They're just like, oh, I hate this and blah, blah, blah. And I'll just raise the deductible on my fully insured plan. And instead of it being a 40% renewal, it'll be a 20% renewal. And instead of spending, $1.2 million a year, now I'm spending, $1.5 million a year. And I'm just going to eat the extra $300,000. So that's kind of what's happened. Healthcare is always counter-cyclical to the extent that there are parts of the country and there are industries that are losing revenue and losing sales. They're going to be forced to make that change. And so you already are seeing that basically in municipalities. If there's anybody who's like, quote unquote, adopting this more so, it's those employers or those municipalities that just don't have the opportunity to increase prices. And they're really getting a lot of revenue pressure. And so then they're kind of being forced to make a decision.
Yep. And on the smaller end of the market too. Typically. I think, I will agree with Eric. I think it's very close to a 401k. And I think in that way, it comes with the good and the bad things from a 401k too, right? It's like, it's helpful in the modern world to have portability of benefits, right? If you're going to change jobs, and there's a lot of workforces where it's like, you're going to change jobs every 4 months, right? Every 9 months. So some level of portability is helpful. I think my biggest concern with ICHRA is around, can people actually, do they have the tools to make good choices? And my general, this is more of a grander statement, but one of my beefs is that healthcare makes people feel dumb. And that is in part why they don't trust a lot of things, and why you've seen a lot of the, trust scores go down. And this is yet another way where we are overwhelming them with acronyms and not enough tools, and they're just going to feel dumb and check out kind of from a broader perspective. That is a concern I have. That said, on the ACA side, if we can get healthier, younger people into the exchanges, that has societal benefit, right? Because I think there has been an issue, and there was a lot of death spiral talk, around the first of the year with the subsidies going away. And so, to the degree that we can kind of, get a younger, healthier population into the exchanges, I think that will drive down costs over time and has some benefit there.
I think that's an interesting dynamic with ICHRA that folks have pressed on. Conversations I've had around it is, hey, especially with subsidies expiring, and it looks like maybe preliminary numbers have come out, and 16% of people didn't pay their first month premium on their plans or something. So it's somewhere between 15, 20-ish%, it's going to drop. And you assume that cohort, because they're on some level of subsidy, maybe they're generally a little healthier. How does ICHRA, I feel like is to what extent is ICHRA dependent on the overall kind of health and risk pool assessment of the overall kind of program, I guess? Does that make sense?
Exchange. Yeah.
Exchange.
I mean, that's where they're going to buy things, right? So to the extent that it's it needs to be healthy for there to be appealing options and for that business to grow.
Yeah. So here, one of the challenges for the insurance carriers that offer those individual plans is they don't know how to underwrite somebody coming from an ICHRA and somebody just coming on the individual market on their own. They don't know how to underwrite those differently. So as a result, they offer them the same premium. And that might not be the right way to do it, because theoretically, the ICHRA folks don't have the adverse selection of wanting to go out and buy insurance because they specifically have a healthcare need that they're going to spend a lot of money on. Well, in the individual market, they do that. Well, the only reason I'm signing up for an individual plan is because I have a specific healthcare need. But if you're really just getting it through your job and the job's giving you $800, maybe you're just getting it because you actually do just want insurance. You just want protection. So theoretically, the insurance carrier should underwrite the ICHRA folks different from the people that are just signing up on their own. But as of now, they don't.
And so in a perfect world, how would they be distinguished?
So these platforms, these ICHRA platforms facilitate the money coming from the employer to the carrier. And then it needs to be, if the employer is given $800 and the employee chooses a plan that's $1,000, then $200 per month, then $200 needs to come from the employee and $800 comes from the employer to get to the $1,000. As opposed to somebody who's just coming onto the ACA exchange, who's either paying all of the premium themselves, or the government is subsidizing some of the premium. And so these companies that act as ICHRA onboarders or ICHRA facilitators, they would be able to cue the carrier, hey, this is an ICHRA member that's coming over your way. you should quote them differently than somebody who's coming in through a different route.
Something I find interesting about ICHRA is when I can remember, I think it was like the Big Beautiful Bill or something, but there was a lot of talk around the current administration wanting to, I don't know, expand HSA, increase the kind of role of ICHRA, and for some reason that got quashed in the current bill. I don't know. I just find that very interesting. I wonder why they did that versus trying to expand it and make it maybe work a little better and turn it into some sort of like, Medicare for all type situation or something where it's still privatized, but you have the HSA to help you pay for certain healthcare things. This whole arena is a little ethereal to me because I hear folks who say the employer should not be part of, healthcare at all. And then I hear a lot into 2026 about the rising role of the employer and how there's so many doing different things. So I'm curious from y'all's perspective, like, what is the role of the employer in healthcare in 2026?
Since we're coming off the heels of the ICHRA conversation, one of the things that I think about is it's kind of a race of not it. So it's like federal government was involved, but then they were just like, there's a stop. And then it's like, oh, not it for certain people. And then it's like employers are now kind of calling like, not it. It's like, we don't want to do this. And that is fundamentally a very understandable place to be in, right? It's like, it's so much like worry, resourcing that any employer has to do to be able to cover these people. So it's a fundamentally understandable position to want to call not it, right? I think for certain sizes of employers. I do think that employers are understanding better their leverage within healthcare. We talked about captives and pooling resources, like that gives them, better leverage from a stop loss perspective. I also think they're just being a little bit louder fundamentally in terms of kind of what the possibilities are and not taking it on the chin. The people that could afford to do that are typically larger companies that, they're not the 40-person employer. They're the Boeings of the world, so to speak. But I do think they're especially like, I think from the clients that we're hearing, it's like they're rethinking their benefit strategy because they're tired of taking it on the chin all the time. And so the one thing that I will say too, from how they approach things going forward, is that like the Occam's razor, like simple as the answer train left decades ago with healthcare. It's like failing that. And we have, the companies that have succeeded have capitalized on inefficiencies, right? There's a lot of, I think, very good companies that are out there solving one gap, right? Making one thing better. And that is great. And, but over time, you just start to layer on and you've got more. And at scale, that is like even more complex to manage for an employer. And so there's a lot of like point solution fatigue. And there are fewer companies that are trying to take ownership of the front door and ownership of the outcomes of those individuals. And I think that is also a direction that employers are headed into in terms of like, as opposed to just stacking on more, like how do we actually change patient behavior to get to lower costing care, better outcomes for this population. So,
yeah, and I would say that because healthcare is so big, right? I think it's over $5 trillion now, right? So employer sponsored plans cover about 60% of Americans. Okay, so it's not 60% of the money because more money is spent on the seniors, right? But it's 60% of Americans are on an employer sponsored plan, and these are rough numbers, and about 60% of people on an employer sponsored plan are on a self funded plan, right? So if you do the math on that, that means about 36% of Americans, so just over a third, are on a self funded employer sponsored plan, and about 24%, so just under a quarter, are on more like a fully insured plan where it's actually the insurance carrier that's carrying the risk. So you basically have a dynamic of even the employer market is very different in terms of like who's bearing the risk, right? For all those self-funded folks, it's actually the employer that's the insurance company, and the quote unquote, Blue Cross, United, Cigna, Aetna, they're just the facilitator. They're just like Visa or MasterCard. They're just facilitating the payment. They're not actually taking any of the risk, right? So it's very different depending upon if if you're fully insured or self-funded. Okay. It's also very different depending upon which part of the country you're in. It's also very different depending upon which industry that you're in, because some industries have very low employee turnover where the employees are there for decades, like utilities. People, I work for the power company. How long have you worked at the power? I've worked at the power company for 35 years, right? And then you've got folks in like retail or or convenience stores. It's like if you're there for 6 months, you're a loyal employee, right? And so the point is that they're super different. It's highly variable. So the role of an employer in healthcare is where you stand depends upon where you sit. So you talk to different employers, they're going to have dramatically different viewpoints on what their role is in healthcare. Some of them will be like, I want out of it yesterday. And other ones will be like, I'm over my dead body. Will you ever take this away from me? That's why in general, I'm a big fan of just decentralization. Okay. Because there is no central planning that's going to quote unquote fix this. There is no way that healthcare can be quote unquote engineered in America to be quote unquote better for everyone. Okay. That is never going to happen. If you want to do that, then go back to the Soviet Union of the 70s. Feel free, right? That is never going to happen. So that's just my opinion. You can have a different opinion. That's totally fine. But it's too big, it's too complicated. And by definition, just know that if you're working in the employer space, and if you're working in healthcare in general, the most important thing is to not try to quote unquote solve healthcare for everyone. It's just to find a niche. And when you find that niche, you find a smaller niche. And then when you find that niche, you find even a smaller niche. When you've gone into a super small niche, guess what? You can still build like $100 million business in that super small niche. Like we're only going to work with restaurant workers in Florida. You probably get a huge business like just with that.
At open evidence evaluations, that's like worth like $10 billion company right there. The restaurant workers in Florida. But yeah, so Eric, to your point around decentralization, I feel like we kind of have the worst of all worlds right now where, it's like there are capitalistic elements and socialistic elements to healthcare, right? And Tiera, would love your philosophical thoughts on this, but I feel like we just need to kind of choose one or the other. And the one that America as a society culturally probably would choose would be decentralization versus consolidation and centralization of everything. But right now you have pockets where there is consolidation, pockets where there isn't, and regulations that help out one entity unfairly versus another. And so then we're kind of stuck in the middle weirdly. So
that is correct. And that's the whole Uwe Reinhardt opinion, the famous healthcare economist from Princeton who has, passed away. But he said that, other countries can have single payer, but America cannot. And basically, and really the reason for that, and this is a quote from Donna Shalala, who was the head of Health and Human Services under Bill Clinton. Okay, this is from a Democrat. And she said the path to healthcare reform is campaign finance reform. That you really cannot have genuine healthcare reform until you have healthcare finance reform. Because I think was it Citizens United that said that corporations can act as people and make donations. And so as long as you have corporations that can make donations, you will de facto have regulatory capture of the government by the healthcare industry itself. And so right now we have rules that are essentially highly influenced by the industry itself, not influenced by patients. So anytime you hear a discussion about healthcare, just know that the priorities of the patient is actually at the bottom, that every other hand is in the till above the patient because they're greasing the wallets of the politicians. And so you can do one of two things. You can either decentralize it and just be like, okay, we're going to take it out of the hands of the politicians. Therefore, they can't have their regulatory capture anymore. Or you pass campaign finance reform. I don't know which way we're going to go, but in my opinion, that's what you would have to address.
Yeah, I think those are great points, Eric. To some degree, in any market evolution, there will always be consolidation of power. And I think you're right in that the consolidation of power has followed the money because of Citizens United, right? So it's like, as opposed to the power being in the voices of large groups of patients, for example. So I think that's totally spot on. But with that said, I mean, I don't think we're ever going to get to one or the other. Like even if that would be simpler, and simple is helpful sometimes. And even when we compare ourselves to other, like, industrialized, Western, nations and whatnot, they're so tiny compared to the messiness that is the United States, that there are things that we can adopt and, try to, instill within the culture, but they're fundamentally very different beasts, right? So, we can do things in California, maybe replicate from Germany, for example, but that's just not going to work for everybody. And so, but yeah, I don't think there will ever be the federal government that's completely out nor completely in. And I will say too, that I think as we're headed towards this like silver tsunami of, people, baby boomers retiring and, becoming very, very expensive. The one thing that I would say is that a way to offset risk in Medicare is to have healthier, younger people in it, right? Just from a general pooling of risk perspective. So I'm not saying that that's what's going to happen by any means. I think perhaps that, well, who knows? But it's like, if you're looking at ways to kind of offset risk and kind of afford that over time, it's like they're going to need different ways of managing it, whether that's through AI, whether that's through, a more diverse population. They're going to need something.
Right. What Tiera just said, that's the exact reason why I work in the employer-sponsored space. Because if I waited to just work with people that are seniors, like a lot of times it's too late. The damage has been done. I mean, I would see
Yep.
people who had diabetes for 30 years, and it's like, listen, I can't save your kidneys. Like, it is too late.
Yep.
And we're only going to get this if we get them younger.
Yep. Exactly.
Yep. Great points. One final thing I'll note on the employer front, is it seems like, especially with AI and new companies, it's maybe a lot more power is in the hands of employers from a optionality perspective over time. So I know of several companies who are setting up, like direct contracting or national centers of excellence, or bundling and unbundling of certain services in certain local markets and those sorts of things. Also empowering brokers on that side of the equation. So I do think there are a lot of elements of this to be optimistic about, you guys included. So
I generally just like being optimistic because it's just an easier way to live. but I would
absolutely. Yeah. It's very easy to get pessimistic very, very fast in healthcare.
Very quickly. Yeah, I know.
Yes. Yeah. So
as much as we complain about stuff today, like, listen, things are a lot better than they used to be, right? It's very, listen, my parents got married in 1968. I'm like, how in the world did you guys get married in 1968? Like, America was collapsing. Like, you had RFK was assassinated, Martin Luther King was assassinated, like the race riots were burning the vast majority of cities in America. You had the Vietnam War going on. I mean, if that happened today, everybody in America's head would explode, right? And like, life goes on. So like, believe me, with as many problems as we have, it's a lot better than it used to be.
Absolutely. Love that. I think that's a good note. And do you know what happened in 1969, Eric? The Texas Longhorns won a national championship in college football. So just keep that in mind in your factoid memory bank. All right. Well, guys, I think we've had a pretty robust discussion today around a few, pretty compelling points and things happening in healthcare. If anybody who's listening wants to get in touch with us or has any thoughts, please feel free to leave them, or I don't know, I guess you could like email one of us or something, find us and harass us. But Tiera, Dr. Eric Bricker, thank you so much for coming on. Appreciate the time, and I'll see you guys next time.
Thanks,
Awesome.
everybody.
Thank you so much, Blake.